Okay. Can you see it?
Yes. Mm-hmm.
All right. So today we're going to talk about oral pathology. And of course, we're going to speak about a lot of the key terms that you need to know for this lecture. And we're going to talk about why it's important and the differences of all the oral pathologies that you guys might see in someone's mouth. So, oral pathology is the study of diseases in the oral cavity. Only a dentist or a physician may diagnose pathologic conditions or diseases. It's important for the dental assistant to be able to recognize the differences between normal and abnormal conditions that appear in the mouth. Many systemic diseases, as well as infectious diseases, have oral manifestations, which means signs and symptoms. The dental assistant should also understand how oral abnormalities affect the patient's general health and plan dental treatment. Before you can recognize abnormal conditions, you must have a solid understanding of the appearance of the normal oral condition. So, normal oral conditions is, healthy mouth. You don't see anything unusual, but we'll talk about what's unusual. So the
Mm-hmm.
doctor will make a diagnosis. He will do a historical, clinical, radiographic, microscopic, laboratory, therapeutic, surgical, and differential diagnosis. He's the one that decides what type of diagnosis. Most times they start with a historical because they want to know family histories. When you go to the doctors, they always ask you if somebody in your family has something. It's important
Mm-hmm.
because sometimes genetic disorders, such as dental genesis imperfecta, may be passed from generation to generation. Melanin pigmentation of the gingiva is common in dark skinned individuals. And medical histories, they can provide information about medication the patient may be taking that can affect on the oral tissues. So here is one example of dentinogenesis imperfecta. This is a hereditary condition that affects the formation of dentin. So the teeth, as you can see, are opalescent and have almost an amber color. Now, the enamel tends to chip away from the dentin and the weakened teeth become worn down. The only way, honestly, to fix this type of condition is two ways: extraction or crowns to cover these teeth, because fillings and things like that will not really cover it. They'll make it look bulky. A crown would be better. Okay. Here is melanin pigmentation. So look at the gums. Okay. And it's considered clinically harmful. Okay. It is most commonly found in African Americans and Native Americans. Just basically, the gums are a little bit darker, not a big deal. Here's something that's called fissured tongue. Okay. So, everybody remember we talked about occlusal pits and fissures, and pits and fissures are grooves in the tooth. Well, some people have fissured tongue, which is grooves in the tongue. The theory is that this is a vitamin deficiency and or chronic trauma. The problem is that the top of the tongue is marked by deep fissures or grooves, and it can become irritated if food debris collects in them, like food gets stuck in it. So the patient with a fissured tongue is advised to brush the tongue gently with a soft toothbrush to keep the fissures clean of debris and irritants. And usually no treatment is indicated for this condition other than good oral hygiene. Okay. So if that type of person doesn't take the food out of those deep fissures, they usually tend to have the worst breath ever. Okay. Now, you guys will probably see this a lot. I have definitely. These here on the bottom are called mandibular torus. A torus is a benign bony growth projecting outward from the surface of a bone. A lot of patients don't even know that this is abnormal because they grew up with it. It started small and it got a little bit bigger. The problem is that in this person's case here, you see that the anteriors are crooked. It probably is very hard to keep their lingual side very clean. The buccal shouldn't be a problem, but the lingual side might be. The other thing is that it's hard to take x-rays on a person like this. And if they need to wear dentures, it's even harder because these bones, and they're hard, okay? They're not soft, they're hard bones. And it's really hard to take x-rays because they're in the way. Here's one on the palate. So right here on the top of the palate, okay, there's another bony overgrowth. So people get them in different places. Some people, the most common ones I usually see are on the lowers, but there are also, again, as I mentioned, on the top. And if they have it on the top, then instead of it being called the mandibular tori, it's called the torus palatinus. Palate is for the top, okay? So again, here's the overgrowth in the midline of the hard palate. Now, here we have what's called the median rhomboid glossitis, okay? And this is in the posterior midline. This is what's called atrophic candiditis. Candiditis is another name for thrush. It presents in the back of the tongue. Lesions are typically less than 2 millimeters. Most but not all demonstrate a smooth, flat surface. This makes the people's mouths or tongues very itchy, okay? Because candiditis can, it's like a, sort of like a fungus, you know, in the mouth, okay? Definitely, as you can see here, possibly this tongue here is coated with food debris that has not been brushed for a while, okay? Now, and of course, we'll go into the different, what can we do, what can be done in a little bit, all right? Now, radiographic diagnosis, the images are excellent in providing information about periapical pathology, internal resorption, and impacted teeth. So here is a periapical x-ray. Periapical is an x-ray specifically for that tooth, okay? And one of the things that we take periapical x-rays is because we could see, or we should be able to see, because in this case here, these molars, the roots are kind of cut off. In this one, it's not, and the arrow is showing something there, and that is an infection, okay? So the pulp became infected as a result of caries. So these white, I'm gonna go over this here, this white on the tooth, on the top of the crown, is fillings, okay? And then they're saying that in this tooth right here, this person had a filling and got what's called recurrent decay, and it traveled down and caused an infection. And these right here is the pulp chamber, canals, and the nerve, okay? And so it had an infection, and there's two options here, root canal or extraction. Now, if you were looking at this x-ray, we've been doing surfaces. This is the distal, this is the occlusal. Now, so we would say a DO. It looks really big, so it's probably also on the buccal and the lingual. Now, over here is the mesial. It's real close, but we can't consider it an MOD. So it's just a DO, and like I said, it looks really big. It's probably a B and an L too. Now, this one also looks extremely big. This is your MOD, and again, it looks like it's on the buccal and possibly on the lingual. And this one looks like it's just on the DO. Okay, so this is why it's important, again, for us to keep on studying our surfaces, our classifications. Again, this one here, because it's posteriors, they're all class 2, okay? Now, here's internal resorption. So look right here. This is a normal canal, okay, nice and thin. But look at over here, something is going on inside of the canal. It could be the tooth often has a history of trauma, or a pulp cap was done. This is where that pulpotomy that we did the other day, maybe a pulpotomy was done. Okay, so we practiced that in class. So this is how the x-ray will look. Now here's what an x-ray will look for a third molar impaction. This tooth is laying down horizontally, okay? Now, you would think that it's only the wisdom tooth that's the problem, but if you guys look real closely, what's happening with this tooth is that it's leaning up against the molar in front of it. So this is your third molar. This is your second molar. This filling over here is only on the occlusal because it didn't touch the distal or the mesial. But guess what is this? This is a huge cavity on the distal. Okay, so mainly this happened because the third or molar is leaning against the second molar, making it very hard for the person to clean it, and food became trapped in here and ate away the enamel, causing a huge cavity. So the choices here definitely is to extract the third molar and decide if they're going to save the second molar or extract it too. Now, we don't really want to start extracting all our teeth because the more teeth we extract, the less we have in our mouth. So definitely a recommendation of a root canal for this tooth would be done. Look how the cavity is inside this pulp. Okay, so these are the horns of the pulp. Again, this is the chamber and this is the canal. So the cavity already has hit right here in the pulp. Now, this here is called angular cheilitis, okay? And if you look at the lips, right here on the corners of the lips, this is usually a deficiency of vitamin B. We'll talk a little bit more about that in a little bit, but these are things that you guys might see in the dental office. Now, microscopic diagnosis. So when a suspicious lesion is present, tissue is removed and sent to a pathology laboratory where it's evaluated microscopically. They take a biopsy. This procedure is very often used to make the definitive, or what we call the final diagnosis, okay? If it's a malignant, it's usually like a white lesion that cannot be diagnosed on the basis of clinical appearance alone. It must be subjected to a biopsy to determine whether it is malignant or not. That's the only way we really know, okay, is by doing a biopsy. Laboratory diagnosis, blood chemistries and other laboratory tests, including urinalysis, can provide information that leads to a diagnosis. Cultures done in the laboratory can be used to diagnose types of oral infection. There's also therapeutic diagnosis. It may be made by providing a treatment therapy, then seeing how the condition responds. So again, I showed you a picture of the angular cheilitis, and I said to you it could be the cause of the lack of the B vitamin. So the doctor may give the patient an antifungal cream, or the vitamin deficiency theory can be ruled out. So, you know, they'll do something to see if it works, and if it doesn't work, then they'll try something else, and that's called therapeutic. Your surgical diagnosis is a diagnosis made on the basis of the findings of a surgical procedure, and it helps distinguish between benign and potentially harmful conditions. So here's another x-ray, and what the arrow is pointing to is a traumatic bone cyst, okay? Now, you guys might see something on the x-ray and not know quite sure what it is. Patients are going to ask you all the time, what do you see? Please let them know that the doctor will be in a few minutes, because you can never, ever say what is on an x-ray. That is for the doctor to say. You can never diagnose, okay? You're only a dental assistant. Now, granted, as you get better, you may know what you see on an x-ray, but it is not for you to say. Now, here's a static bone cyst, okay? So another point, the arrow's pointing to another bone cyst, okay? And the expertise of the dentist is the primary determining factor in the making of a differential diagnosis. So he will be the one to make the diagnosis. He probably will also, again, do testing and maybe even refer to the oral surgeon, okay? So differential is when two or more possible causes of a condition are identified and a differential diagnosis may be made. You have acute and chronic inflammation. Inflammation is the body's protective response to irritation or injury. Inflammation can be acute or chronic. Acute inflammation occurs if injury to the tissue is minimal and short-lasting and the tissue begins to repair quickly. Chronic inflammation occurs when injury or irritation to the tissue continues. So one of the problems with chronic inflammation is that it can lead to formation of scar tissue. And scar tissue does not have the flexibility that the original tissue had, because once you have scar tissue, it kind of becomes a little bit hard. Now, oral lesions. Lesions is a broad term for abnormal tissues in the oral cavity. It could be a wound, a sore, or any other tissue damage caused by injury or disease, and is classified as to whether they extend below or extend above the mucosal surface, or if it lies flat or even with the mucosal surface. So there are some lesions that extend below the mucosal surface. That's your ulcer. That's a defect or break in the continuity of the mucosa that results in a punched out area similar to a crater. There's erosion of the soft tissue. It may be a shallow defect in the mucosa caused by mechanical trauma. An abscess, a localized collection of pus in a circumcised area. A cyst, a closed sac or pouch that is lined with epithelium and contains fluid or semi-solid material. Now, where would you expect to find a cyst or an abscess? Cysts may form on the crown of an erupted tooth, but abscesses are usually found at the apex of the teeth. And is erosion a symptom of disease or injury? It's usually an injury caused by mechanical trauma. What that means is, I'll give you an example. You probably all have had an erosion. I know I had. How? I bite on my cheek, not, by accident. If you bit on your cheek by accident and you get that little sore in the cheek part of your mouth, usually what you do, you keep on biting on it because it's already inflamed. That's an erosion. Okay, so if you never had one, great. If you had one, try to avoid, keep on chewing on it. Sometimes it's hard. You try to avoid it and you're eating something and you bite on it again. And it won't heal until you stop biting on it. Or again, the best thing for that is warm salt water rinses. Now, lesions that are above the mucosal surface would be like a blister. Well, we've all gotten blisters, right, on our feet. Well, you can get blisters in your mouth and they're filled with fluid, okay? Some people also call them vesicles. You may get something called a pustule. It's very similar in appearance to a blister, but it contains pus. Pus can be different colors when it does get popped. It could be yellow. I've seen a little like greenish tint, little brownish tint, because the longer they're in the mouth, the longer the color starts changing. A hematoma, also similar to a blister, but inside a hematoma, there's blood. And then you have plaque. Any patch or flat area that's slightly raised from the surface. Now, this plaque that we are discussing here is not the same as a dental plaque, okay? There's two different types of plaques. Now, lesions even with mucosal surface. Again, I mentioned they lie flat or even with the surface of the oral mucosa and are well-defined areas of discoloration. So, an ecchymosis, which is the medical term for bruising, is an example of this type of lesion. A raised or flat lesion are your nodules, which may appear below the surface or may be slightly elevated, are small, round, solid lesions. And when palpated means that the doctor is touching it, a nodule feels like a pea beneath the surface. Granuloma in dentistry is often used to describe a nodule that contains granulation tissue. And tumors are also known as neoplasm, and a tumor may be benign or malignant. Again, we wouldn't know until we take a biopsy to see what type of tumor it may be, okay? Now, I'm going to explain the difference in how a nodule feels when palpated, if it is malignant versus benign. If the nodule can be rolled, it is a good sign that the lesion is more likely benign rather than malignant. Malignancies are indurated, they are invasive and grab surrounding tissue. You never want to hear that you have a tumor, but if you ever hear that you have one, you always want to hear that it's benign and not malignant, because malignants are usually your cancerous ones. Diseases of the oral soft tissues are leukoplakia. It means white patch. These lesions vary in appearance and texture from a fine white transparency to a heavy, thick, warty plaque. Its cause is unknown, but leukoplakia is commonly linked to chronic irritation or trauma, very often precedes the development of a malignant tumor. And again, plaque is any patch or flat area that is slightly raised from the surface, and this is an example. Okay, so this is your leukoplakia. This white is pretty thick. Okay, it looks like warts. If you ever seen warts, it looks like warts, but they're white. Early diagnosis is important because there's no pain associated with this condition. So usually, also when the patient goes into the office to have their first examination, the doctor usually checks their tongue, under their tongue, on the sides of their tongue. And again, guys, if you're in the patient's mouth and you happen to move the tongue with the mirror and you see something, let the doctor know that you saw something, okay? Here, I just want to point out, here is a tooth with a crown on it on the maxillary, okay? This looks like a all gold crown. It looks discolored though. Lichen planus. This benign chronic disease affects the skin and oral mucosa. Many factors have been implicated in lichen planus. However, the unknown, the patchy white lesions on the oral mucosa have a characteristic pattern of circles and interconnecting lines called Wickham striae. It can cause erosive lesions, and here's what it looks like. Okay, they're usually made worse by stress. If you guys look over here on this tooth, this is a huge cavity. I'll be pointing out different things to you just so you guys can see, even if it's not related to the lecture, because sometimes some of these pictures will show something that I've been wanting to show you guys, and we haven't been able to see them on any other pictures. But right here, again, this is a huge cavity. Candiditis, it's a superficial infection caused by the yeast-like fungus, Candiditis albicans. I mentioned that to you already. Candiditis is a fungus. It occurs under conditions such as antibiotic therapy, diabetes, xerostomia, which is dry mouth. You're going to hear a lot of patients say that they have dry mouth. A lot of it is medication related. And weakened immunologic reactions. It can be the initial clinical manifestation for patients with acquired immunodeficiency syndrome, which is AIDS. Also, diaper rash, vaginitis, and thrush are other common types of candiditis. The symptoms are discomfort of pain, halitosis. If you haven't heard the word halitosis, halitosis means bad breath, okay, halitosis. And again, candiditis is a common oral fungal infection, but actual incidence rates are low in healthy people. So stay healthy. All right, types of candiditis. You have your pseudomembranous candiditis, also called thrush. I mentioned that before. It's a creamy white plaque form in the mouth. Guess what? A lot of children get thrush. Why? Because as babies and toddlers, they put a lot of things in, things that fall on the floor, their pacifier, the bottle, toys. They drop their candy, they pick up their candy, they put the lollipop in the mouth that was on the floor. And so what happens is they get this little white creamy plaque that forms in their mouth. They would have to take some type of medicine in order for that to go away, okay? So always look in your child's mouth and make sure everything they put in their mouth is nice and clean. Hyperplastic candiditis appears as a white plaque that cannot be removed by scraping, and atrophic candiditis is smooth red patches that may appear on the dorsal areas of the tongue and palate. So the good news is the ones that can be removed, that's good news. The ones that cannot be removed is bad news. What they look like, okay? Now the pseudomembranous candiditis, the patients, because you see how red it is, they may feel a burning sensation, a bad taste in their mouth, and sometimes blisters forms, okay? The plaques that can be scraped off, and they rarely bleed. Here is chronic hyperplastic candiditis. The white appearance of the tongue did not wipe off, and it disappeared with antifungal treatment. Here's some right here though on the cheek. Here's your, let's talk about your aptus ulcers. Some people call them canker sores or aptus dermatitis. Some people get recurrent aptus ulcers. It's a disease that causes recurring outbreaks of blister-like sores inside the mouth and on the lips. You have minor and major. Your minor episodes occur fewer than 6 times a year. Lesions usually heal within 7 to 10 days. And your major, this form outbreaks of larger, deeper ulcers that take longer to heal. Early signs and burning sensations and blister formations are the symptoms, and the ulcers form when the blister breaks. And here's your minor, see right here. So again, a lot of people tend to get these who are very stressed. Let's talk about cellulitis. Inflammation spreads throughout the soft tissue or organ. Swelling develops rapidly, accompanied by a high fever. The skin becomes very red and there's severe throbbing pain as the inflammation localizes. Cellulitis associated with oral infections is potentially dangerous because it can travel quickly to sensitive tissues, such as the eye or the brain, okay? So controlling inflammation and treating the underlying infection is the key to managing a case of cellulitis. All right, so here it is. Does anybody have any questions before I continue?
No.
Okay, awesome. Glossitis, and by the way, guys, you can stop me at any time, okay? Glossitis is the general term used to describe inflammation and changes in the topography of the tongue. Oh, black hairy tongue. It may be caused by imbalance of oral flora after the administration of antibiotics. The filiform papillae are so greatly elongated that they resemble hairs. These elongated papillae become stained by food and tobacco, hence the name. So we all have filiform papillae on our tongue. They do resemble hairs. They look like very fine hairs. So people that people that don't really brush their tongue really well, okay. This is also, like they mentioned, it could be antibiotics, but it also could be poor oral hygiene, okay? Never brushing your tongue, okay? The tongue goes through different, have you ever like had something in the nighttime? Milk is a perfect example. Went to bed, didn't brush your teeth, went to bed, woke up in the morning and you have a coating of white on your tongue. It's super important to really brush it off. In a case like this, you know, the longer it's on here, the thicker it gets. The only way to remove it is to shave it off with a shaver, okay? So that looks pretty bad. I have seen that maybe twice in my career. It's gross. Geographic tongue. The tongue exhibits multiple areas of desquamation, which means loss of the filiform papilla in irregularly shaped but well demarcated areas. So this is the opposite of black hairy tongue. They don't have any filiform papilla. The smooth areas resemble a map, hence the name geographic. Over a period of days or weeks, the smooth areas and the whitish margins seem to migrate across the surface of the tongue by healing on one border and extending on another. Only about 1 to 3% get this, and women are affected twice as often as men, and it looks like this. So you see those patches. Okay, some of them are irregularly shaped but well demarcated areas, so they do look like a map. I've already talked about a fidget tongue. Okay, it could be again vitamin deficiency, chronic trauma, and I had already showed you a picture of it. Here's another picture of it. This person has it on the borders and in the middle, whereas the first picture I showed you was more all on here. So remember, no two patients are alike. Everybody's a little bit different, okay? And of course, they're advised always to brush their tongue gently with a soft toothbrush to make sure that the fissures are nice and clean and there's no irritants on it, okay? Pernicious anemia is a condition in which the body does not absorb vitamin B12. People with this condition show signs of anemia, weakness, pallor, and fatigue. And exertion, other signs include nausea, diarrhea, abdominal pain, and loss of appetite. Oral manifestations of pernicious and anemia include angular cheilitis. So remember I showed you that picture with the lips and the two red blisters on the corner? Those are the ulcerations and redness. You also can have mucosal ulceration, loss of papilla on the tongue, and a painful burning sensation of the tongue. The only way to fix that is to get vitamin B12 in the system. Oral cancer. It is one of the 10 most common cancers in the world. The incidence as well as the site or the cancer varies greatly from country to country. Most oral cancers do not cause pain in the early stages, and the thorough dentist is most likely to be the first to detect them. These cancers are fatal if not detected early enough or if left untreated. Here is a picture of what's called squamous cell carcinoma. Okay, it's on the lower lip. Here it is where my arrow is. These type of cancers can quickly metastasize. That means spread to other regions of the body, usually the neck and the cervical lymph nodes. So anytime you see something that you're not quite sure of, you have to make sure it gets checked, okay, just cancer. Now, these are different types. Your carcinoma is a malignant neoplasm growth of the epithelium, that's the tissue lining the mouth. You have your adenocarcinoma, a malignant tumor that arises from the submucous mucus glands underlying the oral mucosa. Sarcoma, a malignant neoplasm arising from supportive and connective tissue, and your osteosarcoma, which is a malignant tumor involving the bone. Remember, before we talked about osteo has to do with bone when we spoke about oral surgery, okay? So in the mouth, it's the affected bones that affect the bones of the jaw, okay? Now, what are the risks of oral cancers? Most often is the tobacco in any form. Alcohol use and poor diet also increase risk. Prolonged exposure to the sun. More than 25% of oral cancers occur in people who do not smoke and have no other risk factors, believe it or not. So here's the destruction of the mandible by squamous cell carcinoma. So I just showed you squamous cell carcinoma on the lips. It spread, let's say, in this picture. We don't know if it started there or not, but it can, as I mentioned. And in this case, this black area here is basically eating up the bone, the jawbone on the mandible, okay? Now, more than 90% of oral cancers are squamous cell carcinomas. That's not a good thing, okay? And it typically begins, as I mentioned, in the outer lining layers of cells in the oral cavity. You have your leukemia, a cancer of the blood, the blood forming organs characterized by rapid growth of immature white blood cells. Oral symptoms of leukemia may be some of the first indications of the disease. Symptoms in the gingival tissues include hemorrhage, ulceration, enlargement, spongy texture, and magenta coloration of the gingiva. Enlargement of lymph nodes, symptoms of anemia, and general bleeding tendencies are typical. 20% of patients with chronic leukemia show no symptoms at the time of diagnosis. And here is what acute leukemia looks like. Swollen, painful, bleeding gums are the most common, as you can see here. Look over here. Look in the lingual. Look how puffy. Look on the top, on the maxillary. You barely can see the teeth. Okay? So this gets to the point where it's so bad that it will cover the teeth in its entirety. Smokeless tobacco. Chewing tobacco or snuff presents a serious health hazard. It is a major concern because of the high rates of precancerous leukoplakia and oral cancer among users of smokeless tobacco. Cancers of the pharynx, larynx, and esophagus occur 400 or 500 times more frequently in users of smokeless tobacco. It's also linked to an increased incidence of tooth loss from periodontal disease. People often think of smokeless tobacco as a healthy alternative to smoking because there's no smoke, but guess what? It is very harmful. Here is a sign of tobacco chewer's lesion. So right over here in this area, the texture is very rough. It's not smooth at all. Okay. Now, therapy for oral cancer. Oral cancers are treated with surgery, radiation therapy, or chemotherapy. And sometimes a combination of these three is used. Radiation and chemotherapy are carcinogenic in themselves. Survivors of one type of cancer are prone to another type of cancer later on. Dental implications of radiation therapy. Xerostomia. So I mentioned this to you before. This is dry mouth. Lack of adequate saliva and the reduced blood supply can cause oral infections, delaying healing, and make it very difficult to wear dentures. Radiation caries caused by the lack of saliva. Radiation caries usually appear first in the cervical areas of the teeth, and the teeth also may become extremely sensitive to hot and cold stimuli. Osteoradionecrosis, bone may be subject to necrosis, which is death after radiation treatment. Remember, we talked about necrosis in endo. It is strongly recommended that cancer patients visit the dentist before commencing radiation therapy. During treatment, the dentist can work with the patient to monitor complications such as dry mouth, increased cavities, and painful mouth sores. And here is a post-radiation effect. Again, the radiation dries up the mouth, so the mouth looks like this. You know, it's most common, osteoradionecrosis is more common in cases of head and neck cancer in which the bone lies within the radiation field. Letter A, or this side, okay, shows radiation mucositis, and B shows post-radiation xerostomia, where they have the dry mouth. Now, dental implications of chemotherapy. So chemotherapeutic agents are powerful drugs that destroy or deactivate rapidly dividing cancer cells. Significant adverse effects of these drugs frequently involve the oral tissues. The chemotherapeutic drugs work because the cancer cells are dividing more rapidly than normal cells are, and because they are dividing more rapidly, they are more susceptible to the effects of these drugs. Your HIV and AIDS, oral lesions are prominent features of HIV and AIDS infection. Oral lesions develop because of the breakdown of the immune system that occurs when the T helper cells become depleted as a result of the disease. The Americans with Disability Act stipulates that a patient with HIV cannot be refused treatment simply because of the disease. The only exception is that HIV patient with a special condition like severe periodontal disease that requires the care of a specialist. So we usually refer them to the specialist. Listen, when you look at a medical history, do you know that a lot of people, a lot of patients are not honest on their medical history? So as a professional, a dental professional, we must treat everybody as though as they are infected. So again, that's why we're very big on washing hands, PPEs, making sure everything is sterilized and disinfected because you want to make sure that everything is clean just in case someone has either missed something on their medical history, lied to you, or they just plainly don't even know that they have it. Now, acquired immunodeficiency syndrome, because the patient's immune system is severely damaged, death is usually caused by an opportunistic infection. An opportunistic infection is one that normally would be controlled by the immune system but cannot be controlled because the immune system is not functioning properly. Some of the lesions that look like HIV and AIDS-related infection may also be caused by other disorders. More than 1/3 of all people living with HIV have oral conditions related to their weakened immune systems. Combination of antiretroviral therapy has made some oral health problems less common, but also involves side effects such as, which is the dry mouth. And HIV patients often die of pneumonia. They are also prone to something called Kaposis sarcoma. Your HIV gingivitis, this is often a bright red line along the border of the free gingival margin, also known as atypical gingivitis. And in some cases, they may be a progression of the bright red line from the free gingival margin over the attached gingival and alveolar mucosa. HIV gingivitis usually progresses to HIV periodontitis, which resembles acute necrotizing ulcerated gingivitis. It's superimposed on rapidly progressive periodontitis. The other symptoms include interproxial necrosis and cratering, marked swelling, intense xerothemia over the free and attached gingiva, intense pain, spontaneous bleeding, and bad breath. And it looks like this. Okay, look how badly this looks here. And the skin, notice the tissue is starting to dry up, so it's turning into this white patch here. Okay. HIV cervical lymphadenopathy, enlargement of the cervical neck nodes, and it's frequently seen in association with AIDS. And it looks like this. And already we talked about candiditis, okay, but it is often the initial oral sign of progression from HIV positive status to AIDS. In a patient with a compromised immune system, candiditis can be a very debilitating and serious disorder. HIV lymphoma is the general term used to describe malignant disorders of the lymphoid tissue. In the immunocompromised individual, it may occur as a solitary lump or nodule, a swelling, or a non-healing ulcer that occurs anywhere in the oral cavity. The swelling may be ulcerated or may be covered with intact, normal-appearing mucosa. Usually painful, the lesions grow rapidly and may be the first evidence of lymphoma. And here's what it looks like. Look how bad that is. Intraoral lymphoma. Okay, so this is in a patient with AIDS. Hairy leukoplakia can be an important early manifestation of AIDS status. A filamentous white plaque usually found unilaterally or bilaterally on the lateral borders, sides on the anterior portion of the tongue. So uni and bi, uni means one, bi means two. May spread to cover the entire dorsal surface of the tongue and can also appear on the buccal mucosa where it generally has a flat appearance. And it looks like this. Your Kaposis sarcoma, one of the opportunistic infections that occurs in patients with HIV infection. Lesions may appear as multiple bluish, blackish, or reddish blotches that are usually flat in the early stages. It is one of the intraoral lesions that is used to diagnose AIDS. Hey class, give me a second, okay?
Okay.
Okay, no problem. Sorry about that, class. All right, so here is a picture. Okay, we're almost finished, so hang in there. Herpes simplex lesions usually occur on the lip. The lesions may occur throughout the mouth and also occur caused by the herpes virus that persists for longer than 1 month, may be an indicator of AIDS. Patients do not have HIV or AIDS may also suffer from herpes, and it looks like this. Your herpes zoster in the immunocompromised patients, the latent herpes zoster virus, also known as shingles, may cause intraoral manifestations in the forms of blisters, and these blisters break and form ulcers. The lesions are very painful. Now, I know you probably heard this because there's a lot of commercials on human papilloma virus, okay? And also it's commonly in immunocompromised individual. The diagnosis is made on the basis of history, clinical appearance, and biopsy findings. Lesions are a common finding in patients with early HIV infection, and these warts appear spiky, and some have a raised cauliflower-like appearance, and they may look like that. Okay. And I still have 20 slides, but I do have a meeting to go to. So I am going to stop it here. And tomorrow I will finish the last 20 slides. Okay.
Okay, teacher, no
Okay.
problem.
All right. Let me just take a quick attendance. Give me a second here. Just remind
Okay.
me too. Just remind me in case I forget that I am on slide 84. Okay. And then let me just take
Okay.
quick attendance.